Can you hear me now?
Yes, Dr. Rajib, you're audible.
Yes. Is that Natalia?
Yes, sir.
Okay, Natalia. I think shall we make a start now? I don't know how many
Yes.
of you are here today. Good afternoon. I'm Dr. Purkayastha. I'm consultant in stroke medicine I was at University Hospital, Birmingham, now I'm in Yeovil Hospital. So I thought I'd start off by, I don't know how many of you are there. How many are there, Natalia, today?
44 has joined, sir. They're coming.
Okay. Please feel free to, I do not like to do PowerPoint presentations because they're very boring and you don't get much from PowerPoint presentations. So I thought I'll have a face-to-face sessions with you. And obviously anyone can ask me any questions should you want to ask me questions. I realize a lot of you have not worked in the UK. So I think it's going to be difficult if you haven't worked in UK to take the PACES exam here. But all I can tell you is PACES is not a difficult exam to pass. Take the PACES exam. If you failed, take it again. If you failed, take it again. So take it again and again until you passed. And believe me, at some point of time, you will pass. I have not passed the MRCP first time, I've taken it twice. So each one of us has to have failure in life. So failing the exam is a good experience. I think you have to learn how the exam is given. So if you take the exam once and you fail, it's not a problem. You can take it again. And you actually learn after you've taken the exam once, how exactly the exam actually happens. Are most of you taking the exam? Are any of you taking the exam in UK? None of you are talking here. All of you are muted. Is everyone muted? Natalia, is everyone muted?
Yes.
Natalia, is everyone muted?
Yes, doctor, everyone is muted. They're listening to you. They'll
Okay.
tap it.
Okay. If anyone wants to speak or anyone wants to ask questions, please unmute your computer and speak. If anyone of you have any queries or have any questions, the session is supposed to be interactive. So please feel free to ask any questions should you want to, yeah? So to start off with the PACES exam, the PACES exam is an exam which lasts about 150 minutes. So there are basically 5 stations you go through. Now, each station is actually 20 minutes. So you have a session, 20 minutes each session, 20 minutes, 5 minutes gap, 20 minutes, 5 minutes gap, 20 minutes, 5 minutes gap, 20 minutes, 5 minutes gap. So the whole exam actually lasts 150 minutes. So the entire exam lasts 150 minutes for your information, yeah? So the station one is respiratory and abdominal examination. That lasts 10 minutes. Station 2 is a history taking station, which again lasts 20 minutes. The third station is actually a cardiovascular and neurological examination. That's also 20 minutes. The fourth session is communication skills and ethics. That's station 4. That's 20 minutes. The last station, station 5, is a very interactive consultation where you actually take a short history from the patient and examine a particular system of the patient. So it's a quick session, but I think station 5 is quite a difficult station because you got to take a quick history, do a quick examination and do everything very quickly. And station 5, you examine the patient for 8 minutes and the examiners are with you only for 2 minutes. So you examined only for 2 minutes. All the other stations we examined for 4 minutes. So those are the 4 stations. And I'd probably like to tell you what we mark you on. So what I'm going to do is I'm going to minimize my screen now. I'm going to show you the examination mark. Is everyone able to see the mark sheets then of the examining mark sheets? Natalia, are they able to all see my computer?
So you have to share your screen. Can you see the option?
Yes. Okay.
Yeah.
Hang on. Can people see my screen? Can people see my screen? Can people see my screen?
Not yet. Have you shared the screen?
Not yet.
No. So how to do that? Hang on. I was going to show some, hang on. I was going to show the examiner's mark sheet to everyone.
It is not shown.
Can you see the examiner mark sheets now?
No,
Are you able to see the examiner mark sheets now?
No, Dr. Rajib, on your screen, can you see the option of share screen? You have to click on that.
Share screen.
Sir, please check your inbox.
My inbox.
WhatsApp inbox. Yes, sir,
Hang
I
on.
have shared you.
Okay, hang on. 1 minute. 1 minute. I haven't got anything on the inbox. Is that Natalia?
Sir, check your WhatsApp inbox.
My WhatsApp inbox. Okay.
Yes, sir.
Okay. So share screen is where? Is it right at the bottom? Is that bottom of the screen?
Yes, sir, it's in bottom.
I can't find it actually. Is that the one? Is that the one? Right at the bottom?
Or you can try Alt and plus S.
Sorry?
Alt plus S.
Control plus S or?
Alt plus S, you can try.
I haven't got an Alt button. It's a laptop. So which is the Alt button? Okay. Anyway, I haven't been able to show you the mark sheet, but I can just tell you what the mark sheet actually shows. The mark sheet actually shows how you actually scored. It would have been very good for you guys to see the mark sheets. I'm not able to show you the examiner's mark sheet. So if you can Google on your laptops PACES examiner mark sheet, you'll find the mark sheets, how the mark sheets are like. So if you just Google PACES examiner mark sheet, you'll probably find it there. Yes. So if you Google PACES examiner mark sheet, you'll probably be able to see it there. Yeah. Right. I've lost you there somewhere. Hang on. Hold a minute. Can you hear me, all of you?
Yes, Dr. Rajib, we can hear you. Can you send me the mark sheet? I'll share my screen.
Okay. Can I email it to you? Hang
Yeah.
on. Just 1 minute. I'll just email it to you. Hang on. What is your email?
Sir, Natalia at MedExam. I'll just WhatsApp you my email.
Okay. Sorry, this is taking a bit of delay. Beg your pardon, it's taking a bit of delay. I'm sorry about this. It's technical problems, you know. But we can go on for more than an hour. That's not a problem. Yeah. Okay. So what is your email, Natalia?
Sir,
What is
I've
it?
WhatsApped you.
Yes. Okay. Yes, that's okay. Sorry. Sorry, give me a minute. I wish this was a bit easier. I'm sorry about this. So Natalia, I've just sent you the mark sheet now. Can you display it for everyone, please?
Give me a second.
How do I go back to Zoom? How do I go back to Zoom?
You are visible, sir. You're audible and you're visible to us.
Okay. I can't see anyone else actually.
There's
How do I go?
78 participants right now.
Sorry?
78 participants are there at the
Okay.
moment.
Yes. So can you get me back? Can I be come as onto the whole screen? Can I see the whole screen? How do I see the whole screen?
You
Do I go
have
back?
to. You
I
have
go back.
minimized your Zoom app.
Can you hear me now? Can you hear me?
Yes, Dr. Rajib, we can hear you.
Yes. I can't see. Can you? Will I log on to my Zoom again because I cannot see everyone? I'll just log into my Zoom again. Yeah.
Sir, we can't hear you now. And please
We are not
unmute.
hearing you, sir.
Yeah.
Can you hear me, all of you? Are you able to hear me?
Yes, Doctor, we can hear you.
Okay. I'll go back to Zoom again. I think I've lost my Zoom connection.
Sir, you have minimized your Zoom app. Can you open your browser? Were you using from browser or the Zoom app?
I was using it through my browser, so
So you have to open your browser.
I will open my browser. So are you guys able to see the mark sheets now? Are you able to display
Yes.
the mark sheets? Yes. So can all of you have a look at the mark sheets and raise any questions about it? The mark sheets have got pass, borderline, or fail, right? Now there are lots of skills there. Some stations you're going to be marked on your clinical skills. So if you look there, hang on. Sorry, I can't get the full, I can't get the full, I can't get the full zoom actually. I can't get the full zoom profile. Hang on. What's happened? I minimized it, I don't know what's happened. Hang on. Will I log into Zoom again? Natalia, will I log into Zoom again? Because I think
No, you don't have to log in again.
I can't
You
see
have to
anyone, you see. I
open
can't
your
see
browser.
I can't see my face. I can't see anything, you see. So I'll just log off and log in again, yeah?
Okay.
Yes. I'll just log off and log in again. Just give me a minute, yeah? I'll just log in
Okay.
again, yeah?
Okay, no problem.
But all of you should have a look at the mark sheets first, yeah? And we'll have some questions on that, yeah? Natalia, can you scroll the mark sheet up, please? Yeah? Can you scroll it up,
Okay.
please? The mark sheet.
Oh, okay, doctor.
Scroll it up. Scroll it up. Yeah. So as you can see from the mark sheet, if you scroll it up, right? So there are 4 stations: respiratory, abdominal, history taking, cardiovascular, neurological, communication ethics, and station 5, BCC1 and BCC2. Can you see that? Can you scroll the mark sheet up, please? The next one, yes. So as you can see from there, you put your name there, you put your examiner number there, and if you scroll up, for the clinical stations, you're examined on your clinical skills, which is physical examination. Number 2 is identifying physical signs, right? Sorry. Something else has come in the middle. Sorry. Sorry. Can you get that page, please? I don't know why this page has come in the middle. Yes. So as you can see, this physical examination, identifying physical skills, differential diagnosis, clinical judgment, and maintaining patient welfare. Now, the clinical sessions you'll be marked on A, B, and C, but in the communication skills sessions, you're not going to be marked on those because you're not going to physically examine anyone. You're not going to do anything else. So the marking is going to be a little bit different from that, right? So that's basically a synopsis. Now you can get a satisfactory pass, a borderline, or an unsatisfactory. Unsatisfactory is fail. I want to tell you one thing. If you do badly in one station, the MRCP PACES, you could actually still pass the exam. So if you do badly in one station, never think you failed. You fail if you do badly in more than one station or do very badly in one station. But normally there are candidates who have done badly in just one station and they've actually passed. So do not ever feel bad that you've done badly in one station, you're likely to fail. So you could do a little bit badly in one station and you could still pass the exam. And as I told you, take the examination as many times as you want. Not that I want it to take you many times, but it is an examination which eventually you definitely will pass. I haven't seen anyone who's not ever passed the MRCP. If it's 1 go, 2 goes, 3 goes, 4 goes, eventually you will pass the exam. So please keep taking the exam until you pass the exam. And I can tell you for sure, you will pass the exam, all right? Right. So let's start off first by doing the stations. So the first station is actually a respiratory station and abdominal examination station. Now, what are the common cases you get in the respiratory station? The common cases you get in respiratory stations are, over my years of examining in the last 10 years, I can tell you 3 or 4 cases which come in the respiratory stations. One, you can get a pleural effusion in the respiratory station. You can get someone who's had a pneumonectomy. And if someone's had a pneumonectomy, normally you would see a scar on the chest, the trachea is deviated and the lungs deviated to one side, and you will not hear breath sounds on one side. So that's another type you can get. So you can get someone with a pneumonectomy, you can get someone with pleural effusion, you can get people with fibrosing alveolitis. It's very common to get fibrosing alveolitis in the exam. And sometimes you can get a patient with COPD with very bad emphysema or bronchiectasis. So you could get bronchiectasis or emphysema in the exam. So those are the 3 or 4 respiratory cases you could probably get in the exam. So it'll be one of these you'll get in the exam out of these 4 or 5. In the abdominal examination, there are only a couple of cases, couple of things you can get in the abdominal examination. You can get someone with alcoholic cirrhosis who will actually have ascites. So he'll have signs of liver disease, have signs of ascites. That's the other thing you can get in the abdominal examination is polycystic kidney. Polycystic kidney is very common for the examination. That's the second thing you can get in the exam. You can get hepatomegaly, someone with a liver tumor, enlarged liver, hepatomegaly with a liver hepatoma or a metastasis in the liver. You could get that. You can sometimes get a hepatosplenomegaly or just plain splenomegaly. And the fourth thing you can sometimes get is you can get someone with a transplant kidney. They'll have a scar of the abdomen and they'll have a transplant kidney. So those are the 4 or 5 things you can probably get for your abdominal station. Yeah. The next thing we come to is station 2. Station 2 is actually is history taking and communication skills. Now I've got a small history for you today, which I probably can share with you on communication skills. This is a station 2 station history where you've got a patient called Daniel Steele. He's a 63-year-old man. You're the doctor in the general medical clinic. And this patient was believed to have hemoptysis and suspected bronchiectasis in the chest X-ray, presenting complaint. So basically what happens is the history will be, I will be grateful if you see this patient who has had hemoptysis for the past few weeks. He has been treated for chest infection in the past, but has not had any respiratory problems. We have arranged for a chest X-ray, which has reported as showing changes consistent with bronchiectasis. Please advise on future investigations and management. Now your task is to interview the patient based on the history, give a differential diagnosis and plan of investigations, and you have to explain this to the patient and answer any questions they may have. So the first thing, most important thing is very important to take a history. You need to take a clear history of what extent the hemoptysis is. You must ask about whether the patient is dyspneic or not. You must ask whether he's got ankle swelling or not. You must ask whether he's got any pleuritic chest pain or not. And the patient has said he's had recurrent chest infections for the last 2 years. He's had pneumonia as a child. You've got to look at the patient's medications as well, what the patient's medication is taking. And In the personal history, the most important thing with anyone with a respiratory case is to ask about smoking. So anyone, any respiratory case, if you don't ask about smoking, you could fail the exam. So anyone with respiratory problem, always ask about smoking. So smoking history is very important. Personal history, occupational history is very important. Someone has had hemoptysis, and travel history is also very important. Now, the patient could clearly have concerns. The patient could say, "Doctor, have I got lung cancer?" Now, you have to behave in a very professional way. Although the patient is concerned, you have to reassure the patient to say this may be right, may not be right. So you have to have a very balanced opinion rather than say you've got cancer, you're going to die straight away. Rather than say anything like that, you've got to reassure the patient and say you're going to investigate the patient further. That's what you need to say. All right. So in this case, if you've got to look for a differential diagnosis, the differential diagnosis probably would be bronchiectasis, chronic obstructive airway disease, and obviously lung cancer would be a differential diagnosis. So those are differential diagnoses you're going to mention. So in the clinical communication skills, you got to mention history of hemoptysis, very important. Must ask if he's a smoker, must ask about chronic COPD, and you must sensitively explain to the patient that lung cancer is a possibility, and you must not offer false reassurance. You must explain that the chest X-ray has shown changes consistent bronchiectasis, and this is what the patient is likely to have. And in the clinical judgment, you have to identify that you're going to investigate the patient for further lung cancer. So a CT scan of the chest is very important here. So you must mention that to the patient. You must also say if it's bronchiectasis, he'll need a long spell of antibiotics, and this may be a chronic problem. So those are all the things you've got to say to the patient at the end of the day to actually explain to the patient what's going on. So you must have, your technique must be right. How you do this must be right. So please feel free to ask me any questions, any of you. Has anyone got any questions? Because this session is believed to be interactive and you guys must ask questions. So has anyone got questions to ask?
Sir, Assalamualaikum, sir. Regarding this respiratory cases, the differential would be like any kind of bronchitis or any kind of lobectomy. If we got what will be the specific differential and how they manage our clinical judgment accordingly, sir? If you discuss few.
If you say because he's had hemoptysis, it's very important to do a CT scan of the chest just to make sure the patient has got lung cancer. If it is bronchiectasis, you've got to mention about bronchiectasis that he needs long course of antibiotics, he needs chest physiotherapy. But you must not, because he's had hemoptysis and because the changes are still showing bronchiectasis, I still think you've got to do a CT scan of the chest just to make sure the patient hasn't got lung cancer as well. So CT scan of the chest is very important as a investigation of choice as well, So you must mention that. Yeah. All right.
Thank you, sir.
Any other questions?
Yes, sir. Our biggest concern, I think many of us face as international medical graduates, is that in terms of presentation to the examiners, that's where we get stuck.
Yes. So I think you must be very systematic. You must be very systematic. You must be very methodical, and the differential diagnosis, you must have a clear differential diagnosis in your mind. So when you present to the examiner, you must say, this is the possible differential diagnosis, So you must keep that in mind, So I think on the one hand, you mustn't say nothing's wrong with the patient. You must reassure the patient too much. You mustn't scare the patient as well. So your position has to be very balanced. So you have to maintain a very balanced position to say it could be this, it could be that. There are lots of possibilities, and we are going to investigate you further to find out exactly what it is really. So rather than give a one-cut clear answer to say this is lung cancer, this is bronchiectasis, you got to say it is likely this is the cause, and we're going to investigate further to find out what's going on. That is the best way to approach the problem. So tell the patient you're going to investigate further, and you're going to find out what's going on. So that would be a good way to answer the question. Yeah. All right. Good. So I've told you about the cases you could get in the abdominal examination, haven't I? So hang on. Well, the next session is cardiovascular and respiratory. Okay, let me tell you now, in the abdominal and the respiratory system, what are the mistakes people often make in the abdominal and respiratory system. In the abdominal examination, never ever hurt the patient. If you hurt the patient, you could fail the exam. So make sure you don't hurt the patient, right? If the patient has got abdominal distension, always test for shifting dullness. There are lots of candidates who are not tested for shifting dullness and actually have failed the exam. The third problem is if you feel the patient's got a palpable kidney, always do a bimanual palpation to see if the kidney is there or not. So when you can feel the kidney, always do it bimanually to confirm that this is the kidney. So those are the few mistakes candidates actually make. And if the patient is jaundiced, clearly mention the patient jaundiced, because some patients do not mention, they do an abdominal examination, but the patient is jaundiced, they sometimes do not mention the patient's jaundiced. So mention if you can see the patient's jaundiced, So those are the common mistakes people make. In the respiratory system, quite often patients do not look at the trachea. When you're examining the respiratory system, never ever forget to look for the position of the trachea. This is something candidates sometimes forget. So always look at the position of the trachea and make sure the trachea has not shifted. If someone's had a pneumonectomy, you'll often find a scar. So if the patient has had a pneumonectomy, has had lung cancer, make sure you look at the scar and mention the scar is there. So those are the common mistakes candidates actually make for the exam. Yeah. I'm just telling you the mistakes from my 10 years of examining the mistakes people make. Yeah. The next session is actually cardiovascular and neurological examination, right? In the cardiovascular examination, I do not think you're ever going to get congenital heart disease in the exam. You're not going to get Fallows, you're not going to get a VSD, you're not going to get ASD. So don't even think you're going to get a VSD or an ASD or a tetralogy of Fallow or something like that. It's very, very unlikely that you will get congenital heart disease in the exam. The common valvular lesions you normally get is mitral stenosis, mitral regurg, aortic stenosis, aortic regurg. These are the common things you get, but you can get a combination of mitral regurg, aortic stenosis, or aortic stenosis, mitral regurg. You can get a combination of everything together. You can have more than one valve that's involved. Common things which people forget. When you're doing the cardiovascular examination, never ever forget to look for the apex beat. Candidates have always failed when they haven't looked for the apex beat. So always make sure you've looked for the apex beat. Candidates have failed because they haven't looked for the apex beat. The other very important thing is when you're doing a cardiovascular examination, always feel the patient's pulse. People are not wearing watches and they don't feel the patient's pulse. But when you're doing cardiovascular examination, please always mention what the patient's heart rate is, what the patient's pulse is. Because although you're doing a cardiovascular examination, you must mention the patient's pulse rate or heart rate. And quite often candidates forget to do that. Very simple things sometimes, very easy, simple things candidates forget to do, you see. So that's what they forget to do. So I'm just telling you the mistakes candidates commonly make for the exam, you see. So that's the cardiovascular system. And if you've also examined the cardiovascular system, just examine the patient's lung bases and look for ankle edema just to make sure the patient isn't a heart failure. So although you're examining the heart, you must listen to the lung bases as well to make sure the patient is not in heart failure, because if the patient is in heart failure, you need to mention that as well. So in addition to listening to the heart, you must also listen to the lungs, although it's a cardiovascular examination, and look for ankle edema just to make sure that the patient's not fluid overloaded. Also look for the JVP if possible. If possible, look for the JVP as well. So those are the things you do in the cardiovascular examination. Yeah, but always look at the pulse. And don't forget to look for the apex beat. So candidates often forget to look for the apical impulse, and candidates often forget to mention the pulse rate of the patient. So these are the two common mistakes candidates make. So make sure you do not make those mistakes. Yeah, that's the cardiovascular system in brief. The next thing we come to is actually the neurological examination. Now, in the neurological examination, you're never ever going to be asked to do a full neurological examination. So the common neurological cases you will actually get is you can get someone with spastic paraplegia. So you'll be asked to examine, you'll be told this patient is unable to walk. Can you examine his lower limbs? So maybe a neurological examination of lower limbs or of the upper limbs. So you can get someone with spastic paraplegia or multiple sclerosis who's got weakness of the lower limbs. That's what you can get, common presentation. The other presentation you can get is someone with peripheral neuropathy. So they can tell you, examine this patient's lower limbs neurologically. Probably the patient's got diabetic neuropathy. So they've got sensory neuropathy in lower limbs. So you'll probably find sensory neuropathy there. So that's another presentation you can get for the exam. A third presentation you can get a cranial nerve palsy. So you can get someone with a third nerve palsy or a facial nerve palsy or a sixth nerve palsy. You can get commonly you get a third nerve palsy, sixth nerve palsy, facial nerve palsy. Those are common. So third nerve, sixth nerve, facial nerve palsy. Those are common palsies you get for the exam situation. The other thing you can get is you can get someone with Parkinson's disease sometimes. So you can just get a Parkinsonian tremor. They can ask you to see a patient with a stroke sometimes. So sometimes you can have a patient with a stroke with a hemiparesis and weakness of one side of the body. So you can get stroke, you can get Parkinson's disease as well. Sometimes you can get rare conditions like Charcot-Marie tooth. A lot of patients with Charcot-Marie tooth can come in the exam. That's a very common presentation you can get, where you get clawing of the foot, wasting of the muscle of the foot, and you can get motor sensory neuropathy in the limbs. So Charcot-Marie tooth also you can sometimes get in the exam. So those are the common neurological cases you normally get in the exam. And other than these, I don't think you'll see very much more of neurology. What are the common mistakes people make in the neurological examination? If the patient is not able to walk, you should always tell the examiner, I would like to see the patient walk. The patient may not be able to walk, but you always must mention to the examiner, doctor, I would like to see if the patient can walk. If the patient got sensory signs, it's quite important to look for a Romberg's test to see if there's got a Romberg's test is positive or not. Common things with candidates forget. Sometimes candidates forget to look for the plantar response. Now, I can tell you this, if you're doing a neurological examination, and if you forget to do the plantar response, you're going to fail the exam, right? Reflexes are quite hard to do, but make sure you do the reflex in all 4 limbs whenever it's possible. Sensory examination, when needed, do a sensory examination is possible. Do it with a pinprick and a cotton wool, and making discrimination between the 2 sides. The common mistakes people make is sometimes they don't also test for the position sense. So sometimes you got to test for position sense. So get the patient's big toe up and down, big toe up and down, look for position sense. Candidates sometimes forget to look for position sense. That's what candidates sometimes miss out. What are the other things candidates miss out? Candidates sometimes do not look for clonus. So if someone's got high tone in the lower limbs, you must always look for clonus. Candidates often don't look for clonus in the lower limbs. I'm just telling you from my experience of what mistakes candidates commonly make from my observations. So that's basically the neurological examination, the cardiovascular examination. I've told you about what cases you normally get. Station 4. Station 4 is normally what we call the communication skills and ethics skills, right? So I've got a history today to read to you for communication skills and ethics, right? So there is a patient. So you have a patient. This patient has got type 2 diabetes and hypertension, and was seen yesterday by an emergency doctor with a TIA. He developed right-sided weakness, speech disturbance after work. The symptoms improved on the way to hospital and fully resolved by the time he was seen. His blood glucose was normal. The patient's diabetes is well controlled and hypertension is well managed. He smokes 10 cigarettes a day. His usual medication consists of an ACE inhibitor and a statin. Aspirin was started following the TIA, and the patient has been referred to the medical clinic for further assessment. On examination clinic, his pulse was 76 per minute, blood pressure was 130/70, no cardiac murmurs, no carotid bruise, fundoscopy was normal, urinalysis showed 1+ of glucose, his HbA1c was 48, and you have discussed this situation with your consultant, who has advised further investigations and treatment with aspirin should continue. Your task is to explain to the patient and answer any questions you may have. So in this case, you have to tell the patient what's actually going on, So basically, you got to tell the patient, the patient will give you a short history actually and tell you what exactly has happened. And you should always like to know what is going on and why. And one of the things the patient will always be worried about is, doctor, am I going to have a stroke again? So this question is patient is going to ask you, is there any possibility I could have a disabling stroke which is permanent? Why has this happened to me at such a young age? Is it possible I may need an operation? Do I need tablets? What is the evidence that stopping smoking will help? And is there any reason why I cannot drive? So those are the common questions the patients could actually ask you. Now you need to know about driving after a stroke. If a patient has got a visual field defect after a stroke, they cannot drive. So that is one complete contraindication after a stroke. If they've had a TIA, often after they've had a TIA, you give them aspirin and you need to check the cholesterol and they need to be put on a statin. If they had a TIA, they need a CT scan of the head, if possible an MRI, if the CT scan is actually completely normal. And they also need a carotid Doppler to make sure they haven't got narrowing of the carotids. So those are the investigations you must mention if you're asked what are the investigations you're likely to do is probably a CT scan, carotid Doppler. You may want to do a 72-hour tape just to make sure the patient is in AF. So the full investigation patch will be CT scan of the head, carotid Doppler, 24-hour tape of the heart just to make sure it hasn't got an AF. As that would be roughly the management plan, and give him aspirin, give him a statin if need be. Has anyone else got any questions? I'm just talking. Has anyone got any questions to ask?
Doctor, for station 4.
Yes. Yes, tell me.
I just want to ask about the duty of conduct.
Sorry, I can't hear you very well.
Okay, I just want to ask about duty of conduct.
Yes.
Okay,
yes.
so should we put it in the ethical issue or in the legal issues?
It's ethical issue, actually, ethical issue.
So we can mention the autonomy, beneficence, non-maleficence, and then we mention the duty of conduct in error scenarios.
Yes, yes, yes. You can mention it, yes.
Okay,
but I think the most important thing is, you see, you must not scare the patient too much. You must have a very balanced position, you see. You mustn't alarm the patient too much. You mustn't frighten the patient too much. At the same time, you mustn't tell the patient nothing is wrong with you. You have to say something is wrong with you. We're going to treat it. We're going to investigate further, and we're going to find out. So you have to give a very balanced judgment of whatever you do, a very, very balanced decision, a very balanced judgment, yeah.
Right. Okay, but like if it is an error scenario, I mean, like there is an error has happened. And as you mentioned, we will tell the patient about the medical actions that we will take. We will try to calm him down. But I mean, then the legal issue is going to be for the case of error. Should we include the duty of conduct there in the legal issue?
I don't think so. I don't think that's needed, actually. I don't think that's needed. Error in what error? What error are you mentioning? What error are you mentioning?
Any kind of error, like medication error. For example, he received a wrong medication.
Yes, you got to mention if he's been given the wrong medication, you got to mention it, that unfortunately your medication isn't right. So you need to mention that, of course.
Yes, we will mention it. But I mean, in the legal issues, then the duty of conduct will be one of the issues that we have to mention to the examiner.
Yes,
so
you have
we will mention the duty of conduct. Should we place it under ethical or under legal?
Well, I think it's both, a bit of both, actually, ethical and legal, both. I think a bit of both, ethical as well as legal. I think a bit of both.
So it don't matter whether we mention it under the ethical or we mention it under the legal.
Doesn't matter, doesn't matter. No.
Okay, thank you so much.
Okay. Does anyone else want to ask any questions?
Yes, hello,
sir. I have a question.
Okay. Are you listening?
Yes, please tell me. Please tell me. You stopped? Hello?
Sir, yes, hello, sir. Can you hear me?
Yes, I can hear you, yes.
Yes, sir. Yes, sir. Sir, I was asking about the statistic. As mentioned, statistic is important in communication station or not. Whether we should know the statistics, like how much chances you have in future for a stroke or something like that. And
yes, they could ask you that question. They could ask you that question. Of course, they could ask you that question. Yes, they could ask you that question. Yes, the patient could ask you the question. They could. Yes, they could. Yes, they could. They could ask you that question. Yes, it's not an unreasonable question to ask. They could ask you that question. Yes, you're right. Yes.
Yes. So if I don't know, mentioning the rights is compulsory, or we can just tell the patient that.
I think if the patient asks you, you don't need to mention to the patient. If the patient does not ask you, I do not think you need to mention to the patient. If the patient asks you, obviously answer this question, but if the patient doesn't ask you, I don't think it's necessary for you to mention that. If the patient asks you, yes, tell him the question. But if the patient doesn't, if the patient actually doesn't ask you anything, I don't think you need to mention that actually. Yeah.
Okay, sir.
Anyone
Thank
else? Anyone else?
Sir, in abdominal examination, if I couldn't appreciate any kind of, shifting downless, so
Yes.
should it need the fluid thrill or no need?
I think shifting dullness is good enough. Shifting dullness is good
Okay,
enough.
sir.
It's more sensitive than fluid thrill. If you can find shifting dullness, I don't think you need to look for fluid thrill. It's not necessary to look for fluid thrill.
Thank you, sir.
Shifting dullness on its own is enough to determine free fluid in the abdomen. Yes, you don't have to look for further fluid thrill. It's not needed. No. Okay. Anyone else? Please feel free to ask any questions you have about the exam. Any worries, any questions, any other questions. I'm just giving you I'm just giving you a rough idea of about the exam. But if you have any questions to ask, if you don't know about the exam, about the PACES, this is the time to ask. Please feel free to ask me. So if anyone has got questions, I do not want to give you PowerPoint presentations because that's terribly boring. It's not educational. PowerPoint presentations. I don't believe in PowerPoint presentations. So I thought if there's I think the discussion should be interactive. It should be coming from you guys. So you guys need to ask me questions and I can ask questions. So if anyone has got questions about PACES again, please feel free to ask me. All right. Has anyone got any questions?
Excuse me, sir.
Yes.
So it's important to have a differential diagnosis. Should we focus on differentials or we have to make a definite diagnosis for these diseases?
You must always have a differential diagnosis all the time. Differential diagnosis is very, very important. You'd have a differential diagnosis and then you give a diagnosis, but it's very important to have a differential diagnosis all the time. All the time you must have a differential diagnosis. Yes, very important.
And so suppose we arrive at a specific pathology and suppose we arrive like COPD or something. So should we have a detailed management of that with dose and duration, or so we have to apply for empirical therapy?
You just get, if someone has got COPD, you just mention what the patient will need. You see, does the patient?
For example, sir. Yes, sir.
Can you give me an example? What you want to say? Tell me what you want to say. Yes.
So I'm just asking. Suppose we have arrived for diagnosis. Suppose we have diagnosed that the patient is suffering from COPD. So,
Yes.
when we have the management of that patient, so should
Yes.
we say the detailed management of each and antibiotic and these medicines, or just empirical therapy we have to mention?
Give whatever treatment you're going to give. Just mention whatever treatment you're going to give. So if does the patient need nebulizers or the patient needs inhalers?
Yeah.
Does the patient needs chest physiotherapy sometimes? The patient may need antibiotic if they've had an infection. If the symptoms are very bad, if the peak flow is very low, they may need a course of steroids. The steroids will then be changed to a steroid inhaler after that. After they've completed an oral course of steroids, they may need to go on to steroid inhaler and a salbutamol inhaler. And if the inhalers are not very effective, they may need a nebulizer. So you can mention if the patient's oxygen saturations are very, very low, they may need oxygen at home, depending on what the oxygen saturation levels are like. So you need to mention all those things in the modalities of treatment. Yeah.
So that means that each and every section has different scoring marks. Suppose we have arrived on differential diagnosis, definite and management system.
Yes. If you look at the chart, can you look at the mark sheet? So differential diagnosis. Each one carries same marks actually. So physical examination, identifying physical signs, differential diagnosis, clinical judgment, each one of them have got the same marks, in terms of marks, the marks are exactly the same. So differential diagnosis doesn't score more marks than physical examination, But if you fail in the physical science, if you fail in the physical examination, you're quite likely to fail the station. So if your physical examination is wrong, if identifying physical signs are wrong, you're probably your differential diagnosis, even if it is right, you'll still fail the exam, because you're going to score very badly in the others, because your clinical judgment will be impaired if your investigation is not right, if your diagnosis is not right, your differential diagnosis won't be right, your clinical judgment won't be right, so you're probably going to fail the whole station. Yeah,
thank you,
because if you fail in one, you fail the other, you fail the other, you fail the other. Sometimes it's like a pyramid. You see, if you fail in one, you fail everything. You see at the same time. Yeah.
Okay, thank
Hello,
you, sir.
sir.
One more question, sir.
Yes.
Hello.
Yes, please.
Um,
Please ask me.
Sorry, can you please just repeat the common things on the abdomen, station 1, abdomen and respiratory? Sorry.
The cases you normally get. Did you want to know the cases you normally get in abdominal respiratory? Is that what you wanted to know? I can't hear you.
Yes. Yes, that is what I wanted to know.
Yeah.
Sorry. Yeah.
The cases you normally get in abdominal respiratory is abdominal cases you normally get someone with cirrhosis and ascites or chronic liver disease with ascites. That's one you get. You can get a polycystic kidney. That's the second one you get. You can get hepatosmegaly, or you can get hepatosplenomegaly, or you can get someone with a transplant kidney. Those are the five or six you normally get in the exam. Yeah, someone with a transplant kidney. Yeah, those are the 5 or 6. I don't think you're going to get anything other than those I've told you. Yeah.
Respiratory.
Yes. Respiratory, I think I've told you, haven't I? Respiratory, I've told you, haven't I? The cases you may get a respiratory. Have I told you?
Sorry, I came in late.
Yeah. Respiratory, you can get someone with pleural effusion, someone with a pneumonectomy. Lung cancer with a pneumonectomy is the other one. You can get someone with COPD, and you can get someone with fibrosing alveolitis. Yeah, those are the common ones you can get in the exam. I'm telling you of the most common ones you get in exam. It's all going to be fitting around these, you see. You don't get my things which are very much different from these, you see. Yeah.
Thank you, sir.
Yes.
Examination, sir. One more question in communication station.
Sorry. Yes. What did you
One
want
more
to
question
say?
in communication station, sir.
Yes, tell me.
Yes, sir. Yes, sir.
Yes.
Can we refer to other specialties while communicating the patient regarding the disease? Like if someone has neurological disorder, can we mention that you will be further guided by the neurology department or not?
You can always say that. Yes, you can always say that. If someone's got a neurological problem, you can always say that. That's not going to be a problem. That's not going to be a problem. Yeah.
Thank you.
Okay. That's never going to be a problem. Yeah.
Sorry, sir. Can you hear me?
Yes. Yes. Can you hear me? Yes.
Yeah. The problem just now you mentioned about that if the surrogate asks you regarding like statistic, like
Sorry?
how many percentage, like statistic, how many percentage they can get stroke in the future. If let's say we don't know how to answer this question, how should we tackle it with a professional way?
The professional way of saying is you can just say there's a possibility of you having stroke in the future. If you do not know exactly the percentage, you can say there is a possibility of you having stroke in the future. That's the most diplomatic way of doing it. If you do not know the exact statistics, just say there's a possibility of you having a stroke in the future. That's all you can say, nothing more than that. Just be politically correct and be diplomatic sometimes. Sometimes you've got to be diplomatically and politically correct. You're being politically correct because someone with a TI has got a risk of having a stroke. If you don't know the exact figures, you just say, yes, you've got a possibility of having a stroke in the future. Obviously, if the patient asks what the statistics are, obviously then you're stumped. But other than that, you just can say there's a possibility of you having a stroke in the future. That's the best way to deal with it, actually. Yeah.
Thank you, sir.
Yes.
Examination
Sometimes you've got to be a bit political, you see. Sometimes you've got to be a bit political when you don't know the correct answer. Yeah. All right. Far away. Tell me.
Examination of the trachea should be done in the sitting position or the lying down position. Is there a difference?
Any position you can do it. Sitting position also you can do it. Lying position you can do it. Doesn't really matter. Any position is okay. Anyone else? Any other questions?
And can we get like a radial nerve palsy or foot drops in the neurological examination?
You can. It's quite rare. You can, but it's very rare. Normally, you don't get cases like that. Normally, you get a spastic paraplegia or a cranial nerve palsy or something like that. That's a more common thing. You can get an oculomotor nerve palsy or a facial palsy or sixth nerve palsy, something like that, rather than just a peripheral neuropathy. But you can rarely get a peripheral neuropathy, just one nerve involved. You can get it. It's very rare. I haven't seen much in the exam, but it's very rare. You can rarely get it. Yes, you can rarely get it. Very rare for the exam. Neurological, very rare for the exam.
Sorry, sir. One more question. Regarding if let's say the trachea is centrally deviated, it's located at center. Should we proceed to the posterior part of the chest wall examination or maintain, like go from anterior to posterior?
just follow a system, examine the chest anteriorly first and then go posteriorly. So first feel the trachea, examine the chest from the front, do the percussion, palpation, do it from the front. So follow the system, palpation, percussion, and then auscultation. Follow that regime you see. So first you do feel the trachea, where the central knot, do a percussion of the chest, and then do the auscultation. That's how you should do it. Auscultation, the first front of the chest first and back behind. It's best if the patient is sat up rather than the patient lying down. You get better information from that. That's what you do, I think. Yeah.
Hello.
Doctor, I have one question.
Sorry.
Hello. Yes,
Sorry,
I
yeah.
want to ask about. Yes, doctor. Thank you. First, I want to thank you. Then I want to ask about the measurements in clinical stations, especially 5. Yani, when I should do measurements, in which case, yani,
I
we should
can't
do
understand what you're
measurements
trying to
by
say. I can't understand what you're trying to
yes,
say.
yes. When we should do measurements by tape measurements in the examination in station 5.
I don't think you need to carry a tape with you. I don't think you're expected to measure anything really. I do not think so. We
Okay.
normally don't
Like
expect you to measure
if
anything.
patient has yani the height
Sorry?
at the same time in some cases like ankylosing spondylitis in the occiput wall test at the same time in the disproportionate tall stature as in Marfan. No need, doctor. Is it right? No need for tape measurement
I
tape.
don't think you need to ever measure with the tape in the MRCP exam. PACES exam doesn't
Okay.
ask you to measure with the tape. So you don't need to take a tape with you. That's not needed actually. That's not needed
Okay,
for
thank you.
Yeah.
Okay, thank you.
Anyone else?
Hello.
Yes.
Can I examine the respiratory examination from the back, or is it is there any chance of losing mark in the mark sheet?
You got to examine from the back as well as the front. Both sides have to be examined. You just can't examine the back. You must examine from the back as well as the front. Both parts of the chest have to be examined. You just can't do the back. Back and the front both have to be done. Yeah.
I see. So can I examine to start with the back?
Do it whatever way you want. The best way to do is to feel the trachea first, do the percussion after that, and then the auscultation. So palpation, percussion, and auscultation. That's the regime I would follow. Palpation first, feel the trachea, do the percussion, and then do the auscultation. That's how I would do it. Yeah. Anyone else?
Excuse me, sir. Excuse me, sir.
Yes.
A lot of candidates, they are asking many questions. I think it will be easier that first you complete the overview, and then if someone has any question in their mind, then they can ask about it.
Okay.
This
Right.
session is gonna become too long.
Yes, so I'm going to the last station now. The last station is called station 5. Now, station 5 is what we call a brief clinical examination. And in station 5, what happens is you normally have 2 cases. You spend 8 minutes with each case. At the end of 7 minutes, you get an alarm, and you can spend 1 more minute to do the extra bit. And at the end of 8 minutes, you finish. And the examiners only have 2 minutes to ask you questions, right? The thing about station 5 is, you see, station 5, they'll give you a very short history, and it's probably dedicated to examination of one system. So the history will tell you what system to examine. For instance, they could probably tell you this is a patient who's hypertensive, who's on a thiazide diuretic, and who's been having swelling of both the joints, right? So someone is on a thiazide diuretic, is hypertensive, has got chronic renal failure, has complete swelling of one of the joints, right? So what is the first thing that goes through your mind? On a thiazide diuretic, renal failure, and swelling of one joint, what's the first thought that goes to your mind? Gout, exactly,
Gout.
yes. So they will ask you to take a brief clinical history and perform a thorough clinical examination. Now, if you want to do a neurological examination or respiratory examination and all that, that's not going to be relevant for the patient. So all you need to do is the patient is complaining of joint swelling, just need to examine the joints first. If you have that time, then you examine the chest, examine the lungs, and examine the other things, you see. So focus in station 5, you not need to focus on the system you think is most relevant. For instance, they could give you a patient with COPD, and they could say, this patient has been breathless for last 6 months, he smokes, he's a heavy smoker, and he smokes 10 cigarettes a day. He's very breathless at rest. You know straight away this is likely to be a COPD. So examine on the respiratory system. Don't have to do neurologic examination, don't have to do abdominal examination. So spent about 5 minutes taking a quick history, 2 or 3 minutes quickly examining. At the end of the 8 minutes, the examiner is going to ask you 2 questions. For only 2 minutes, they'll have to ask you questions. And in those 2 minutes, the examiner will decide whether you've done right or wrong. So station 5 is can be quite difficult sometimes because you need to focus on one particular system to examine, and a quick examination, quick history taking, and then the examiner will ask you. So that's station 5. So I think that's why I've finished all the 5 stations to give you a brief overview of all the 5 stations. So if you have any questions again, please, I think we're nearly coming up to 1 hour, aren't we, Natalia? Natalia, are we coming up to 1 hour? Are we coming up to 1 hour nearly?
Yes, sir. It's almost 1 hour.
Yes. Okay. Okay. So I will be more than happy for any of you to ask me any questions you have for me, please. Anything to do with the PACES exam, please feel free to ask any questions. No question is a silly question. No question is a stupid question. Ask any Sorry. Can you, anyone for any further question? Anyone with questions?
Sir, yes, sir. Sir, a question regarding station 5.
Yes.
If you are assessing the patient and you ask some extra question or you go for some extra examination, will it gonna be wrong with you, sir?
I can't understand what you're trying to say. I can't understand your question very well.
Yes, sir, when you are assessing a patient in station 5,
yes,
if you ask some extra question in the history and you do some extra examination, that is not needed basically. So
yes.
Is the examiner, he will.
I think it's how relevant it is to the case, you see. If, for instance, you've got a patient with COPD and you talk about the abdominal examination and think the patient has got cirrhosis, or you talk about gastroesophageal reflux and talk of peptic ulcer, obviously the examiner is not going to be happy. So in station 5, you've got to concentrate on one particular system, because the history will give you what particular system is at fault. So concentrate on that particular system really, and then focus your examination, focus your questions on that particular system, because you will probably know what system is actually involved and focus on that system really. That's what you should do.
Is it okay if you are at the same time you are taking the history and you are examining the patient?
No, take the history first and then examine the patient. Don't do both together.
Yes,
take the history first and then examine the patient. Just time yourself. Give about 3 or 4 minutes to take the history and 3 or 4 minutes to examine. So have the timer, have the watch on you, and make sure you divide your time equally between the two. So 4 minutes history, 4 minutes examination. So you know how much time, because at the end of 8 minutes, the examiner will ask you to stop,
Yes, sir, is it important to ask the concern of the patient and deal it within these 8 minutes?
Of course, you can ask if you have any concerns. Yes, you can always ask the patient's concerns. Yes.
Yes, sir. And you must deal it in this 8-minute time.
Yes. You have to deal with it compassionately. You see, you have to deal with it compassion, because there is something called skill G. Skill G is maintaining patient welfare. So if you say something horrible to the patient or upset the patient or offend the patient, if you're marked for skill G, because I know some candidates have really upset the patient. They've said you've got lung cancer. They've said you're not going to live for very long. The patient has got very upset. So that's a skill G. You see, when you speak, they communicate very badly with the patient. And often if you get a skill G in more than one station, you could actually fail the exam. So skill G is no one normally has a skill G. Normally people don't upset the patient normally, but there have been candidates in the past who have really upset the patient, And if you really upset the patient, you get a skill G, and skill G means you could fail the exam. Yeah.
Okay, sir. Got it. Thank you.
Any other questions? You've got time
Yes,
for
sir.
questions. Yes.
I have a question. Sir, if we want to examine the lower limb, like in station 3 neurological examination,
Yes,
but
yes.
the patient had wearing something very tight, like they're unable to completely expose the patient. Is it possible to start the examination while exposing, not means if it's difficult to completely expose and it's taking the time?
No, you need to completely examine the lower limbs to expose the patient. I don't think they're going to give you a case where you cannot completely expose the patient. You have to completely expose the patient to a full neurological examination. You cannot do a neurological examination without full exposure. So you must ask for the full exposure to patient, because they're not expecting you to examine a patient without full exposure. So the full exposure must be done. Draw the curtains and get a full exposure. So you must have full exposure. Yes.
Doctor, I want to ask also one question regarding some like psoriasis and ankylosing spondylitis, there is association, and in the like ankylosing spondylitis, sometimes the patient came with aortic regurgitation. If I ask in the history, there is any palpitation or chest pain, and the patient said no, there is need to screen in examination. So I need to do a cardiovascular examination or to auscultate the aortic area. If the patient deny any symptoms.
Depends. If it's a station 5 patient, you may not have the time to do it. But if it's in one of the other stations, if it's in a cardiac station, you probably will have to do a cardiovascular examination. But if it's a station 5 patient, you may want to examine the heart very quickly just to make sure there's no aortic problem. Yes, you may want to do that.
Okay,
yes.
you should do it. Okay.
Anyone else? Any questions, any queries? Please feel free to ask. No question is a stupid question. No question is a silly question. Please feel free to ask. Yeah.
Sorry, sir. To measure the JVP, do we need to bring in ruler?
No. No need to. You do not need to take a ruler or tape for the exam. Any other questions? Anyone?
For the abdominal exam, do we have to kneel when we're doing the deep palpation, or is it the superficial palpation?
It is always better if you do. It looks more professional.
Sir, do we have to check the blood pressure in case of cardiovascular examination?
Normally, don't ask to check the blood pressure, but when you present to the examiner, you said, I would also like to have examined the patient's blood pressure. Mention to the examiner that you would have liked to examine his blood pressure as well. So the examiner knows that you've thought about it. So mention to the examiner that I would have also liked to have examined his blood pressure as well. So the examiner will know you're thinking about it, So even if you don't have checked the blood pressure, just mention to the examiner, yes, I would also have liked to check his blood pressure as well. That's what you need to do. Yeah.
Thank you.
Any other questions?
If the PACES state Asia, we are possible to get leprosy, or the PACES is in Asia, can we get leprosy or congenital heart disease, uncorrected congenital heart diseases?
Sorry? You normally don't get congenital heart disease in the exam. Very rare. I've never, in my years of examining for PACES, I've never seen congenital heart disease for the exam. I haven't. If you get congenital heart disease, it'll be very unlucky. But I haven't. In the 10 years I have examined, I've never seen congenital heart disease present at the exam. But if you get one, I'm not saying it's not going to come, but it's very, very rare to have it come in the exam. I haven't seen congenital heart disease being present. But if you do get it, I'm sorry, I can't say. Sorry? Sorry? Any other questions? Any other questions? Any other questions?
Do we need to count the pulse and the respiratory rate? The cardiovascular and respiratory? Do we need to counting? count the pulse and respiratory rate.
Respiratory rate you may not have to count, but pulse you need to count, I think. Okay.
Hello, sir.
Yes.
Sorry, can you please just go over the station 5 common scenarios? Is it only rheumatology? Is rheumatology the commonest?
You can get any, you can get cardiovascular, you can get respiratory, you can get rheumatology, you can get endocrinology, you can get anything really. You can really get anything. But the history will often tell you, the short history will often tell you which which system you need to go for. You see, a short history will often tell you which system you need to go for.
Oh, okay. Thank you.
All right.
Thank you.
Are we all done? Everyone's happy? Did you find it useful?
Yes, sir. Thank you.
Yes.
Very, very much. Thank you very much.
Did you find it useful at all?
Thank you, sir. It was very useful. I regret not joining early. I was on a journey.
Yes.
Yes, we would be happy if you, Professor, send us the link for WhatsApp group, please.
Yes. Okay. Are we done then? Are we finished for the day then, Natalia?
Thank you.
Natalia, are we finished for the day?
Yes, Dr. Rajib, we're done.
We're done? Okay.
Yeah.
Have you guys enjoyed it? Have you guys benefited from it at all?
Yes,
sir.
we did.
Definitely.
Yes, we did.
Okay.
It was very helpful. Thank you.
Yes. Okay. Okay.
Thank you, sir.
Thank you. Thank you. Okay. Bye-bye. Good luck. Good luck for your exams. Good luck to all of you for your exams. Good luck. All the best. Good luck.